Assalamu alaikum. Our lecture now about the physiological changes of pregnancy and labor, and this is presented to you by Assistant Prof. Dr. Wasan Alsafi. Pregnancy, it starts by the fertilization of the secondary oocyte by the male sperm forming the fertilized ovum. This fertilized ovum passes from the site of fertilization, which is usually in most cases in the ampullary area of the tube, toward the uterus where implantation will occur there. This journey takes about 5 to 7 days after fertilization by the effect of proteolytic enzymes from the trophoblastic cells which digest the cells of the endometrium. The placenta is formed by proliferating cells from the blastocyst, which is the trophoblast, and the endometrium, which is the decidua. This diagram or picture shows to you where the oocyte is ovulated from the ovary and picked up by the fimbria of the tube. This oocyte passed to the ampullary area, which is the widest part of the tube, where sperms comes there and fertilization happens. This fertilized oocyte will passes down towards the endometrial cavity. This process is facilitated by the ciliated epithelium of the lining of the fallopian tube. Then the fertilized ovum, blastocyst, will come to be implanted and forming the new embryo there. Function of the placenta. The development of the placenta with its villi surrounded by lakes of maternal blood in the large blood vessel sinuses, which serves many functions. It carries nutrient from the mother to the fetus, and it is the source or way for nutrition to pass to the fetus, to the growing fetus, and the waste will be excreted from the fetus to the blood of the mother and then to the excretory system of the mother. Oxygen is transmitted by simple diffusion, so always there is transmission of oxygen from the higher concentration to the lower one. This dissolved oxygen in the maternal blood passes to the fetal blood by means of pressure gradient between both sides. While CO2 is formed from the fetus, excreted also by diffusion through the placental membrane because of its high solubility. It is 20 times more rapid than the oxygen. So rapid excretion, there is no accumulation of the CO2, so there is no hypoxia in the fetus. Glucose molecules transfer to the fetus by facilitated diffusion by means of carrier molecules in the trophoblastic cells. Fetal waste products are excreted by simple diffusion through the fetal membrane, depending also on concentration gradients. This picture shows to you simply focusing the points about the function of the placenta, which is transferring of nutrient and waste product, enzymatic function, barrier function, protecting the fetus, immunological function, it has some role to secrete the immunological factors towards infection, storage, and for endocrine function as there is secretion of many hormones from this placental tissue. We will talk about the physiological changes in the body of the women, of the pregnant women. Volume homeostasis. Pregnancy is a condition of chronic water overload, that's to say fluid retention. About 8 to 10 kilo of water is retained during the whole process of pregnancy. The majority of it goes into the extracellular fluid. Most of it contributes to the plasma volume expansion, and it will lead to increase in the cardiac output, increase urinary blood flow. There is active sodium and water retention in the pregnancy. In the kidney, there is enhanced tubular reabsorption of sodium secondary to increased aldosterone, estrogen, and deoxycorticosteroid secretion. Also, there is increased glomerular filtration rate, GFR, and arterial natriuretic peptide, which favors sodium excretion. Also, there is decrease in the oncotic pressure due to the decrease in the albumin level, aiding to have edema. So, there is an increase of the physiological edema, especially of the legs and dependent part of the pregnant lady. Cardiovascular system, since there is the fluid retention normally physiologically in the pregnant lady, this will result in decreased hemoglobin concentration proportionally, leading to dilutional anemia. Also, there is decrease in the hematocrit concentration, decreased serum albumin with resultant increased stroke volume. There is also increased renal blood flow. The heart clinically will be displaced to the left and upward because of the growing uterus and increasing size of it in the abdomen. The apex is moved laterally, apparent cardiomegaly, sometimes on chest x-ray. It's also physiologically, but minor degree. There is increase in the systolic fluid flow murmurs at the left side, left lower sternal border. Some have transient diastolic murmur. This is the CVS changes during a pregnancy, and this table shows to you points in focus. Heart rate increased, especially in the first and second trimester. Blood pressure, usually it decreased, and this decrease, especially in the first and second trimester, and returned to the baseline level in the third one. So most of the women comes to you in the first or second trimester complaining of relative hypotension. So you have to reassuring her that this is normal physiological changes. The cardiac output, because of the increase in the blood volume, is increased about 45% above the baseline, especially at the end of the third trimester. Stroke volume also increased, and it peaks at 16 to 24 weeks of gestation. While there is decrease in the systemic vascular resistance, and mainly the most decrease happens in the mid-pregnancy, and this is why we will have hypotension or decrease in the blood pressure, because there is increase in the cardiac output, but with it there is decrease in systemic vascular resistance, so the blood pressure will decrease. Pulmonary vascular resistance, as we mentioned, is also decreased to facilitate increased perfusion of the blood and rapid exchange of CO2 and gaining more O2. 30 to 50% increase in the cardiac output, as we mentioned. Usually, the blood volume from 5 liters in non-pregnant state reaches to 7 liters. As we know, cardiac output equals to stroke volume multiplied by the heart rate, and both of them increase, so the resultant cardiac output will increase. Heart rate is also increases as early as 5 weeks gestation, with increased loudness of S1 and S2 with splitting of S1. So once we hear more loud S1 and S2, this is physiologically. Loud S3 after mid-pregnancy can be detected. There is peak at 32 weeks of gestation, increase in the pulse rate, 15 to 20 beats above the baseline. The stroke volume is also increased as early as 8 weeks gestation. As we mentioned, it peaks at 20 weeks with a 20 to 30% increase. The blood pressure equals to, as we mentioned, cardiac output multiplied by systemic vascular resistance, and the systemic vascular resistance decreased, so the cardiac output is increased and the blood pressure will decrease. Systemic vascular resistance decreases to a minimum at mid-pregnancy with a gradual rise toward the term, as we mentioned, but still 20% lower than the non-pregnant lady. So this will equilibrium or equalize or keep the blood pressure of the woman in normal, non-hypertensive women about to be normal. This reduction in systemic vascular resistance due to hormonal vasodilatation, nitric oxide, prostaglandins increased, and others. The blood pressure changes. The mean arterial blood pressure decreased. As we mentioned, mainly and mostly the maximum decrease happens in the mid-pregnancy. it increases to baseline in third trimester. Diastolic blood pressure is measured by muffling, and nowadays they depends on the disappearance of the sound, of the diastolic sound, which is more accurate. Cardiac output also in labor, in delivery, increased about 20 to 35% of the normal value.